Good morning, Professor Memet Ozek. I am very happy to meet you in Istanbul, and thank you very much for all experts, medical patients, for such a good results of the surgery. We know that you are one of the best neurosurgeons worldwide for pediatric neurosurgery and for rhizotomy. Okay, and talking about rhizotomy, what kind of patients can benefit of this, and what is the effect of this surgery?
Okay, rhizotomy is one of the surgeries we are using to treat spasticity. There are other things that we are doing, but the best candidate for rhizotomy is a child who is between 3 and 6 years of age and is spastic diplegic. That means both legs are affected, but there is not a big problem with the upper extremities, and the child has good body control, is not falling down from the chair. Of course, this is the ideal candidate, but only 50% of our patients on whom we did rhizotomy is the ideal patient. So we use rhizotomy especially for CP children, cerebral palsy, because there are other reasons for spasticity: head injury, spinal cord injury, neurodegenerative diseases. But the good candidates are cerebral palsy spasticity. It's a surgery that you do on the back side of the tumor, in the lumbar region. And the main idea, the main philosophy of the surgery is to interrupt the impulses we get from the world around us. It's tactile, it's noise, it's light, everything is information. And in CP kids, this information is sent to the brain in an exaggerated way. Therefore, the answer is also exaggerated and they are spastic. So the idea was, if I interrupt this signal, I may change the muscle tonus to a normal way. And it has worked. And this surgery was described 100 years ago. It's not a new thing. Of course, the technology has developed, but it's not new. There are certain important things that the family has to know. Because in CP kids, of course, the family is psychologically devastating and you have to exercise every day with the child. This surgery doesn't help you in diminishing the time of physiotherapy, so you have to continue with the physiotherapy. You just give the patient a normal muscle tonus, which gives you the chance to develop much faster, but you have to work, you have to exercise, okay? Because in every CP child, there is a damage in the brain. The brain will be never normal, and the child does not know how normal looks like. If you have a movement problem right now, till now, you were normal. Till now, you were normal. So you can differentiate. I am not normal now, but before that I was normal. You can compare. These children, they were never normal. We are trying to put them in a normal condition of our idea. Therefore, after surgery, they need minimum 2 years of intensive exercise program to teach their brain how the normal tonus looks like and how they can manage this normal tonus. It's not a miracle, because most of the patients, they think after surgery we will not go to rehabilitation, we are not going to exercise, and the child will start to run. No, it's not that. But it's a very effective surgery. Especially for those children who has the chance to walk, it's the best treatment. And we are not allowed to be late, because the success rate of the surgery goes down after a certain age, which is around 8. And the oldest patient we have operated was around 15, 16 years of age. But the best results are with the younger ones.
And is it possible to do this surgery before 3 years old, or it is recommended to wait?
The youngest we did was 2.5 years old.
Mm-hmm.
The reason why we are pushing that way, because till the end of 3 years, our neuroplasticity still works. That means you can achieve with physiotherapy the best results till the end of the 3rd year. So my principle is, do your best with your own hands, and let's see what you did. And then we can push this patient from here to here with the rhizotomy. Because if we do the surgery here, we elevate the patient till here. But you can manage this with pure physiotherapy, so why not? Surgery is always the last option. Let's do first whatever you can do by your own, and then I will add some additional activity to your clinical status. Therefore, let's work very hard till the end of 3rd year of your life.
Do you provide some recommendation for further rehabilitation for the patients? Do you cooperate with rehabilitologists? Because many of
yes, because around 50% of our patients are from other countries. Therefore, right now we have a team of 7 physiotherapists. 2 of them are very experienced. We call them chief physiotherapists. Okay, and they can speak English. One colleague who speaks now Arabic, and one all the Balkan languages. Unfortunately, nobody with Russian. Hopefully, I will find somebody. Okay, so we have a certain now Zoom connection. We don't ask the families to come back for control studies to Istanbul. So every week, certain times, Zoom meetings, and the family can contact his or her physiotherapist directly through internet, and they got with collaboration, or they observe the patient and we record that. And then, okay, this step is well, now you have to start with this type of exercise, and they are showing from here, and mostly the mothers are taking care of the child on the other side. So pandemia helped us a lot to use this Zoom meeting and Zoom educations. Very, very good.
Am I right that the patient should continue the rehabilitation for 2 more years, or it depends, it can be the whole life?
Yeah, depending on the clinical condition.
Mm-hmm. And what will happen if the patient has the surgery and he says, okay, it's enough, and they will not continue with the rehabilitation? He will go back to the previous situation?
Not that way, but there will be no good progress.
Mm-hmm.
And another important thing that the families has to know is, regularly the scenario is like this. The patient gets the information from the local doctor, the child is CP. Good. They start to work. And there are some, good steps. The natural history of the disease is like that. Till 5-6 years of age, they develop in some sense, never normal, but they make progress.
Mm-hmm.
Then 6, 7, 8, it's a parallel way. They still work, but there is no development. And then it goes down. Why? Because the child starts to get taller and taller. It's biology, right? Mm-hmm. Okay. Now, the problem starts at that point, because if you have spastic muscles and you start to grow, the human being, if we get taller, the main thing is, in fact, our legs are getting longer. The body is not becoming that much as the legs. There are two structures in my legs, bone and muscle. In a spastic child, bone grows, but the muscles not. Therefore, the range of motion gets limited. Let's say I can open my upper extremity 180 degrees. If my bone, humerus, gets longer, the muscles remain short, I can open till here. After 10 centimeters, I can open like this, so I stay like this. Therefore, if you stop with the exercise and sportive activities, for example, swimming is very important, this and that, the family says, I had rhizotomy, I worked 2 years now, I'm gonna stop. If the child is still getting taller, then you are in danger. You may go back, yes. Therefore, when I talk to the families in real life, I always say, look, for girls till 14, 15 years of age, for boys 18 years of age, you have to exercise in some sense. Exercise does not mean that you have to go to a rehabilitation center always. You can go 4 times, 3 times a week to a swimming pool. This is also rehabilitation exercise, okay? But you have to do something.
You thought that rhizotomy is one option. What kind of other options, surgical options, do we have for cerebral palsy treatment?
Okay. So the simple thing is, of course, botulinum toxin injections. So we have a motion analysis lab here. So we move, so we ask the patient to move, and it's a computer system, so we can get information which muscles are more affected, which muscles should be our target. So again, botulinum toxin injection may be one option. For patients with focal spasticity, that means only one extremity is problematic, we use selective fasciculotomy, which is a surgery on the nerve which is innervating the problematic muscle. So with the motion analysis, let's say we figure out that the problem is to open the hand. So I know which nerve is responsible, musculocutaneous. Okay, I do a surgery from here on musculocutaneous nerve to find out which fascicles are creating spasticity. This is a surgery. Another one for the treatment of spasticity with other etiologies, head injury, this and that, is implantation of a baclofen pump, ITP, intrathecal baclofen pump. This is one surgery. And then for patients who has also some involuntary movement problems, so movements like this plus spasticity, we use DBS, deep brain stimulation. Okay, so different surgical techniques depending on the clinical status, age, and then also the mental status of the patient. And most important thing is what the patient asks for. We have another surgery which is called pallidotomy, which we use for very severe patients. I got patients already 12 years of age, never been able even to sit on the bed like this. And the family wants, just please relax our child so that we can take care of him easily. We use pallidotomy. This is a small nucleus in our brain. We put a needle and we practically burn an area which is 3 millimeters in diameter, and the patient is relaxed. But don't expect that the patient gets up and starts to walk, just to help for the caregiver, okay? Therefore, the wish of the family, the expectation of the family is also very important. Because as a doctor, sometimes you cannot fulfill their desire. This happened to me yesterday, for example. I examined a patient who is 8 years old, even does not have head control, is just lying. And if I ask the mother, what is your expectation? Oh, we know the status. What I want is he has to walk around and, should be able to take care of himself. I cannot take care of myself by my own. Okay? I need some people to support me. So this is something that nobody can achieve. Then, of course, you need some additional people. Therefore, we have also a psychologist in our team. Somebody has to explain the family that this is not possible. And if you start as a doctor with the treatment of a child, you never will be well accepted because I cannot fulfill their desires. So this type of talks between the doctor and the family is also very important.
Speaking about rhizotomy, can we achieve the same result with the physiotherapy, with the exercises, as we have with the surgery?
The answer is very easy. No. There are very nice studies in the literature, meta-analysis, comparing physiotherapy alone, rhizotomy plus physiotherapy. The result is dramatic in favor of rehabilitation plus rhizotomy. So there is no discussion.
Okay, thank you very much for so.
It was a pleasure.
Thank you for